Welcome to the Gastro Girl Podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Garland.
Hey everyone, welcome to the third in a series of 4 podcasts brought to you by Artilix. And we are so excited today because we have a special episode of the Gastro Girl Podcast where we're not just going to ask questions and interview our guest today, but we're actually going to listen to a really exciting presentation. And our whole goal with this episode is to really highlight the important role of patient-provider communications related to this collaborative care, shared decision-making in IBS and especially IBS-C in particular. So without further ado, I'd like to introduce Dr. Drossman and Johannah Ruddy, and we welcome you back again.
Well, thank you. It's good to be here again. What I'd like to do is to say something about communication in general between patient and provider, and then hone down to look at it in terms of constipation. So we're going to give you the background of what the key elements are, tips and techniques, and then we're going to show 2 videos where this would play a role of a patient with IBS-C and constipation. So beginning with the communication part, a few years ago, I did a survey of patients. I basically just listened to the patients who came to me, and they came up with some very interesting comments spontaneously. Doctors don't believe me. I know this is real. There must be something wrong. You don't think it's in my head, do you? Sometimes I feel like I'm going crazy. Nobody knows what I'm going through. Those kind of questions come up, which I think speak to a lack of good communication between patient and doctor and an understanding of what DGBI is. We also did an actual survey with the IFFGD about 12 years ago, and we found that patients are not satisfied with care. When we asked them about how satisfied are they with all types of treatments, and not satisfied, a little bit satisfied, somewhat, very, and extremely satisfied, only about 8% were very satisfied or extremely satisfied. The rest of them were just a little bit or not at all. So there was another study that came out using word clouds and asked them to describe in 2 words what their doctor was like. And it's remarkable. I wish for those of you seeing it, you can see it. But the biggest comments that came out were rushed, hurried, busy, unconcerned, uninterested, even condescending and arrogant. So there are a lot of negative views toward doctors, and I want to try to explain to you why that might be occurring.
Could I just jump in 1 second, Dr.
Sure.
Drossman? I want to refer to this study that came out at the annual scientific meeting at ACG, where it looked at the disease burden and care-seeking behavior of patients with IBS-C. And going back to your study that you did over 12 years ago, today, this study found that only 12% of patients felt their current treatment plan keeps their IBS under control. So that speaks volumes about how many patients are dissatisfied still 12 years later, getting worse.
Right. It's a very similar issue.
Yeah.
So why is this happening? I think one of the biggest things we're dealing with are healthcare system constraints. There is a tremendous amount of burden that comes on doctors now in terms of administrative tasks, the EHR. We also know that insurance reimbursement favors procedures over face-to-face time, which cuts into the time that doctors spend with patients. And we have actually a graphic here, and I'll explain to you the graph of comparing 2 studies from 2005 to 2016. And the amount of time of face-to-face time with the patient dropped from 55% to 27%. It's half.
Wow.
It's half the amount. And if you look at the desk work or the desk time with the electronic medical record, it tripled. It went from 15% to 43%. So that's one of the big constraints. The other thing that occurs is that there's an attribution that may be different toward doctors toward patients with IBS versus inflammatory bowel disease or pancreatic disease, and this is a study where we showed that GI fellows made greater attribution of the patient's illness being real when they had an organic disorder as opposed to a functional disorder. They thought the problem was more serious. The patient was more disabled. The doctor was often liking the patient more with an organic disease than a functional GI. And that has to change. And we base that on the dualistic system, where we've learned over the years through mind-body dualism that if you don't find something structurally, then maybe it's not real or it's psychiatric. And that's where the Rome Foundation and a lot of people working in DGBI, neurogastroenterologists, are trying to educate patients that this is a dysregulation of the brain-gut axis. It's a physiologic finding. It's not something you see by X-ray or endoscopy. And here's a cartoon that really demonstrates that from the New Yorker. It has a patient lying in bed with her eyes quite wide, her mouth kind of closed in a level of kind of non-acceptance. And you have an internist and a psychiatrist standing by at the bedside. And the psychiatrist stands by waiting expectantly while the internist says, well, the old body checks out. Let's see what Doc Atkins here makes of the old mind. The message there is he's saying, this doctor, we don't find anything wrong medically, then it must be psychiatric. And of course, that's totally wrong. And so that's what we have to try to change. We are also trying to change moving from doctor-centered to patient-centered care. This has been going on over 20 years now, since the Institute of Medicine promoted the concept of patient-centered care. And what I mean by doctor-centered care, that's the typical emergency room situation where the doctor is in control. Someone has to have a gallbladder out or is GI bleeding. And that's okay. They have to do the endoscopy. They have to decide on surgery or endoscopy. But when you have a chronic condition or DGBI, like IBS, these are chronic conditions where there are multiple decisions that have to be made. And it's not the doctor's role to make them for the patient. The doctor and patient should participate equally. The patient is active in the decision-making. The doctor looks at the patient's whole world, including psychosocial factors. He uses or she uses communication skills and empathy to convey an understanding and the impact of the illness. Then the doctor provides the options for treatment, and the patient makes the choices. So they're mutually deciding on the care plan. The research has shown by that collaborative model, there's far greater adherence to medication. Patients stay on the ones they choose, and there are better clinical outcomes in terms of symptoms, healthcare costs, and the like. And this is a study we did recently in 2021 on communication skills in gastroenterology. And we looked at an evidence-based review, and we tried to see if interpersonal communications improved the patient and provider experience. And they did. They improved the health of the patient, the provider experience as well, and healthcare costs. And they also found that communication skills training and specific techniques led to patient satisfaction, perceived provider friendliness as judged by the patient. So when we talk about communication skills, we're showing improving diagnosis and clinical decision-making by active listening, addressing the agenda, showing empathy and validation, creates a collaboration of care, a mutual trusting. It offloads the provider from taking too much responsibility because it's empowering the patient to participate in clinical decisions. It also establishes meaningfulness. I think we know in our training of physicians that when patients get satisfaction in caring for their patient, when providers get satisfaction in caring for patients, it becomes more meaningful to them. They're more satisfied. and the patients are satisfied as well. The other interesting thing is that it does save time. An effective interview saves time because you're getting the key features of the diagnosis. So it's really a benefit to the patient and the provider. So when you're seeing a physician, there's really four elements. One is the doctor is getting the information, and good skills gives you a better access to that information. The doctor is also providing education and reassurance. It's establishing a therapeutic relationship using the model of a collaborative care, and you're implementing treatment. Now let's talk a little bit about satisfaction. We know that communication brings patients satisfaction. This is not what we used to call HCAHPS. You know, in the hospital, they have what's called HCAHPS, which is measures to get adequate reimbursement through Medicare or through the hospital billing system. It's not whether the room is clean or the medications come on time. It's the patient judging, is the doctor humane, technically competent? Is the doctor interested in psychosocial factors? And does the doctor provide the needed medical information? That's what has been associated with patient satisfaction. Johannah and I did a study about a year ago, early 2022, where we looked at what are the elements in the patient-provider relationship that led to the patient having greater satisfaction in their care. And what came up is that likability. The patients needed to like the doctor. They wanted the doctor to know about their case, not be thumbing through the chart during the visit. They wanted the doctor to accept their point of view, to be available, to be responsive to questions, to make sure that the patient understands, is trusting, and so on. It goes on like that, being honest. And then the negative factors that were associated with dissatisfaction was if the doctor seemed rushed, not concerned, was rude, or interrupted, or didn't do a physical exam. Now, another element of communication is what we call engagement. If you could see this slide, you see two people, the patient and the doctor, sitting next to each other, looking at each other with good eye contact. If this were a video, the doctor would be making affirmative nods and gestures, creating a partner-like relationship. So engagement is the two of them working together toward common goals, which is often nonverbal. And then the final point is satisfaction relates to the patient and the doctor working together in a collaborative model. When the patient likes the doctor and trusts the doctor likes the patient. It's a two-way street, just like a marital relationship. It's the collaboration and the way they see each other that makes the difference. So with that in mind, I want to go through maybe 7 or 8 elements of the communication, and then we'll show the video. The first is the doctor needs to listen actively. People think they're listening very often when they're in a conversation, but a lot of times they're not totally listening. They're waiting for the other one to finish so they can say what they want to say. And so active listening is basing what you say next, not on a preset agenda, but on what the patient tells you. You want to identify the patient's agenda, and patients will have agendas. Sometimes they come in with it and say, I'm under more stress, I'm not getting better. But a lot of times it doesn't come up until during the visit. I'm worried about cancer. People, am I really crazy for having these symptoms? That kind of thing. And there are some questions I think every doctor should ask. What brought you here today? What do you think you have? What worries or concerns do you have? And what do you feel I can do to help? Those 4 questions are pivotal in the first visit. The next thing is to empathize. Now, empathy would be a statement like, I can see how difficult it has been to manage with your pain. Because what you're doing there is you're reaching over to the patient, you're creating a bridge. You're not asking questions about the symptoms themselves, but you're trying to connect with the patient. And Teresa Wiseman, who's a nurse about almost 30 years ago, did a study looking at healthcare providers of what empathy was. And there were 4 elements. Seeing the world as others see it, that is, seeing how they're seeing their illness, perspective taking, not judging what they say, accepting it, understanding their feelings around that, that is, recognizing the emotion and communicating that understanding. Now, validation is another element of communication. And validation means accepting what they have to say, even though you may not necessarily agree with it. So if a patient says, people say this is due to stress and I know it's not. Well, you have a little bit of education to do, but what you can first say is, I can see you are frustrated when people say this is due to stress and you know it's real, because the misunderstanding is the patient thinks when you talk about stress, it's psychiatric. And by proper education, you can educate to show and validate their feelings and say, but stress can play a role. Your symptoms are causing distress, and we have to deal with that too. We also want to set realistic goals. Patients who have pain for 20 years, you're not going to eliminate the pain in a few months. It's going to take time. You want to educate, and the way you educate is to elicit the patient's understanding, address their misunderstandings, provide information consistent with the patient's frame of reference, and check the patient's understanding of that. Same thing with reassurance. You want to find out their worries and concerns, validate them, and respond to their concerns. And then, as I said, it's collaborative care. You want to negotiate. We have medication A. It causes these benefits. It has these side effects. Medication B has these benefits and these side effects. What do you think? Which do you prefer? Let's talk about it. And then finally, the last element is to just be available to the patient. The doctor needs to be listening actively and being available when issues come up, like loss of a parent or a spouse, early trauma, and things like that. What I'd like to do now is play the video. I wonder if, Jackie, you have any questions about that before we
Yeah,
go into
I
it?
think this really lays a very strong foundation for the importance of collaborative care and shared decision making. And you've outlined some really great points of what the doctor needs to do in an appointment. The patient also has a role too, to prepare for the visit, to be able to be honest and upfront with the doctor about some of the symptoms they're feeling and not being embarrassed and all of that. So I was hoping maybe after the video, we could talk a little bit about a little more about the patient's role in effective communications too.
Yeah, and what the video we're showing is where Johannah is simulating the patient.
Oh, great.
So the issues will come up, and then afterwards we'll answer some of your questions. So
Great.
let's play this video. Ms. Simpson, I'm Dr. Drossman. How can I help you?
Hi, Dr. Drossman. I'm here because I'm having a lot of abdominal discomfort, and I just feel like I can't go.
What do you mean by the discomfort?
It's like a sense of bloating and fullness. I think because I just can't seem to go.
I see. You mean, do you feel constipated?
Yeah.
Can you say more what you mean by constipation?
Well, I'm only able to go maybe once or twice a week. And when I am, it's really hard to get it out.
Do you need to strain?
Definitely, yes.
So do you need to strain to get the stool started, or do you have to strain throughout the bowel movement?
I have to strain throughout the entire bowel movement.
Okay, and then if you do have a bowel movement, does the discomfort improve?
Yes, but I haven't been able to have a bowel movement or I've been able to feel like I've gotten it all out in a really long time. In fact, sometimes I kind of have to, this is embarrassing, I'm sorry, but I have to kind of help it out. Like I have to push it out myself.
I know this is hard to talk
Yeah,
about.
I'm sorry.
So how much is this affecting the quality of your life?
Well, I mean, quite a bit. I've struggled with constipation most of my life, even as a kid, but it's gotten worse recently. It's hard to focus at work because my stomach feels so bloated, and then I certainly don't want to go out after work. So, I'm just kind of feeling isolated.
Why do you think it's gotten worse recently?
Well, I'm going through a divorce, unfortunately, which is really difficult. Trying to balance work and kids and everything. And so it's just a lot of extra just drama and stress going on right now.
Yeah, there is a lot going on. And maybe we can talk about the divorce a little bit later.
Okay.
Is there anything else you want to mention that would be important?
Well, I've seen a couple of other doctors for this. Their recommendations have just been to increase fiber, which really makes my bloating feel worse. And so I need a better solution. So I'm hoping you have a better solution for me.
Well, I'm glad to work with you on this. What I'd like to do now is maybe you can get into a gown. We'll do a physical exam.
Okay.
I've reviewed the records, and afterwards we'll get together and come up with a plan.
Okay, great.
So that was the first part. Of course, we had to, in just a couple of minutes, put in a lot of elements. Normally, we would take more time. But what we are trying to address here, and I'm going to have Johannah speak to that point, is the challenge of patients talking about constipation, the elements of it, and doctors eliciting it through proper questioning. Johannah, maybe you want to make some comments?
Yeah, Johannah, because you were very open and honest talking about very potentially embarrassing topics, and you did a great job as the patient. So what are your tips for patients in that situation like you did?
Well, I mean, in the video, you see, the patient is reluctant to divulge some of that embarrassing information about, how much she's having to strain during a bowel movement, the manual maneuvers needed with the hard stool and that sort of thing. And, for a lot of patients, myself included, that's not something that's easy to talk about with anyone. And with a new provider, this is the first time that I'm seeing this doctor. So I don't have a relationship with him yet. It's brand new information and relationship here. So I think one of the tips for patients is to understand that you are not going to reveal anything that the doctor has not already heard. So understanding that you're not probably going to, have any sort of situation that they haven't already dealt with or heard before. And so in that regard, just, that maybe understanding that this may be embarrassing for you, but it's important for the doctor to understand exactly how the constipation is, how long you've had it, everything around the symptoms in order to be able to provide adequate management options for you.
Yeah, I wanted to point out, you mentioned two important things in that interview, a lot of important things, but two struck me initially. One was the fact that you talked about the manual manipulation. That shows the doctor that you're really struggling with this, as embarrassing as it is. That information is going to help get a more effective treatment plan. And the other thing you mentioned that I thought was so powerful was the discomfort after taking fiber. Yes. And how much that wasn't working for you and it was making your symptoms worse. So I just want to call that out for our listeners, because those are little facts that the doctor, who's very engaged, if you're not watching this on YouTube or a video, the doctor in this video is really looking right at the patient, really like they're having a very meaningful conversation. He's very engaged with her. So I think that helps with the comfort level of the patient too. You feel open. The body language is very open and receptive.
And there were validating statements. I said, I know this is difficult to talk about. That can be very reassuring.
Yes.
To patients. There's also a diagnostic component to this, because when you ask people what constipation means, it means different things. We've done research to show it's straining, it's hard stool, it's infrequent bowel movements, it's incomplete evacuation, and it's manual maneuvers. And those have different treatments. What we're leading to here is this patient having, in addition to IBS-C, pelvic floor dyssynergia, where the muscles don't relax in the pelvic floor. And that element comes out through talking about straining and manual maneuvers. And it's hard enough for patients to say they're constipated, but to say they strain is hard to do. She just said, I can't go. And you had to facilitate what it meant.
Yeah.
Yeah, I
Mhm.
think for her to reveal the treatments too that she's already tried, that's really important for patients to remember, even if it's just diet that they've tried or over-the-counter remedies, like you mentioned, fiber. Maybe they've tried some, over-the-counter laxative products. All of that's going to be important for the doctor to know, so that they can take that into account when they're considering management options for you.
And
Yes.
that really leads to the next video, unless you have another question.
Let me just ask one quick question. The physical exam, for those patients who may wonder, why is he doing a physical exam if she's complaining about X, Y, and Z? Could you just briefly describe the importance of the physical exam and why it should be done in this instance?
Sure. Well, of course, I would also say, as we've learned from our communication work, that having a physical exam is in itself therapeutic for patients, to know that the doctor's engaging, looking for other things. Johannah's talked about this in her own story about she went to doctors and she just sat on the exam table and they never got examined.
Yeah.
But in terms of for this condition, the first thing I'd be looking for in the abdominal exam, is there any abnormalities there, any masses or anything to suggest a tumor or something like that? I'm also very important to look at the colon and examine for tenderness. And then particularly on the right side, what we call the ascending colon, if you're very, very constipated, you could be backed up in stool, and you can feel that by the exam. The other element is the rectal exam, which you're doing to evaluate for fissures, which can occur if you have a hard bowel movement to cause some bleeding and pain. And you're also evaluating for pelvic floor dyssynergia. There are as many as 10 things that you can identify through a rectal exam. Most people are not being trained as much these days about that, but that's where good gastroenterologists can teach. And we're looking for pelvic floor dyssynergia. We're able to have the patient squeeze and relax the levator muscle, the pelvic floor muscle, and then to push down gently and to see that it relaxes. With pelvic floor dyssynergia, it tightens up, and that would move to a different kind of treatment, as we'll see in the next video. Well, based on our exam, and I've reviewed the records, it looks like you have what we call chronic idiopathic constipation or functional constipation. Okay. And you also have what's called pelvic floor dyssynergia or dyssynergic defecation. You have some fullness in your right side of your colon, which suggests to me that you have some retention of stool there, and we sometimes call that colonic inertia. Would you like me to show you what we're talking about?
Yeah.
Well, this is a diagram of the colon, and the job of the colon is to absorb water. Stool comes in as liquid, and the colon absorbs the water to form the normal stool. Okay. When you have constipation, motility is slowed down, and then more water is absorbed, and that leads to a harder and less frequent bowel movement. And with the evidence of stool on this side, you have significantly slowed transit.
Right.
In addition to that, you have dyssynergic defecation. Now, this is a diagram of the rectum and the anal opening, and you notice that it forms a right angle. Mm-hmm. That's a continence mechanism that keeps stool from coming out. Now, when you have a bowel movement, this muscle called the puborectalis or the levator ani relaxes, and you can see that straightens out and you have a more normal bowel movement. And so in your case, this muscle doesn't relax, and that would explain why it's straining and hard to get it out.
Right. Okay.
I hope that's helpful to you.
Very helpful. Thank you. So what do we do now?
Well, there are a few things we can do. First of all, we want to not take fiber anymore because fiber can create more fecal mass when you have slow transit. Okay. In addition to that, we're going to put you on what's called a secretagogue. There are several medications that increase the amount of fluid to counteract the overabsorption with the constipation. Okay. And then for the dyssynergic defecation, we're going to have you do anorectal motility to confirm this. Okay. By the way, on the rectal exam, you have this. You don't have a rectocele, which is something else that can cause difficulty evacuating. Okay. So after you get the motility study to confirm this, we're going to set you up for biofeedback, which is a way that you can retrain those muscles to relax.
Okay. All right.
Okay.
That sounds great.
So you agree with the plan?
I think this sounds great. I'm excited to get started, and thanks very much.
So what we'll do is we'll set up the procedures, and I'll see you back in a month and see how you're doing.
Perfect. Thank you.
So that's the second one. And maybe we should talk about that. I just wanted to mention our book, which talks about a lot of this as well.
We talked about she was diagnosed with chronic idiopathic constipation, which there's really no cause of it per se. But how does that compare to IBS-C? Would the same process that you went through to ask the questions have the same result for IBS-C patients, or how would it differ?
Yes, I know that this is interchangeable, whether we're talking IBS-C or constipation. The difference primarily is that patients with IBS-C have pain as a dominant feature. Now, patients with chronic constipation can have some discomfort, but if it's pain, then we would look at that as IBS-C. So in fact, the treatments are very much the same with the medications.
It would seem that it would be hard to determine which is which from a patient perspective, like chronic constipation or IBS-C.
Right. And even within Rome, we're looking at this as on a spectrum, part of a similar spectrum of disorders, whereas the people with IBS-C have more in the way of what we call visceral hypersensitivity, that the colon being filled with stool causes more pain because the nerves are more sensitive. But the treatments could be very much the same.
Very interesting.
Yeah, I mean, we've talked a lot before, and Jackie, you've talked a lot about the importance of patient education. And that's why you have GastroGirl and why you do this work. And I think it's important for patients to be able to get education right off the bat from their provider that's really validating of their symptoms. It provides a nice baseline of understanding of what's going on, not just with the diagnosis, but with the treatment. So they know what to expect, how the treatment's going to be working, the potential side effects, when they're going to see benefit, because we know with secretagogues, you see benefit after 3 to 4 weeks and maximum benefit after 6 to 8 weeks. And so understanding all of that is going to be really important so that they're keeping on track with that treatment plan. And then that ability to call in and have that accessibility if they have any questions throughout that time. And you see in the video that Dr. Drossman says, "I'll see you in a month." He's already set up that next appointment, making himself available, and that continuity of care is established right off the bat.
Yeah, what I loved in the video was that Dr. Drossman showed the patient a diagram of the colon and what was happening. And it kind of just, as the patient, did you feel like, okay, this makes sense to me, and it's not so, I mean, you still are probably uncomfortable with what you're feeling symptomatically, but did you feel a sense of relief a little bit, seeing the actual diagram and understanding what was happening?
Absolutely. I think, myself and other patients who we've talked to who have had this similar education model of seeing an image or a manipulative of some kind and explaining what the process is that's happening in your body is very validating and really helps you to go, okay, great. I understand now exactly what's going on. I have confidence in this physician. I have confidence in our shared decision-making around the treatment, and I'm ready to move forward. And I think that's really, really important for patients.
Yeah. And to go onto your book, and we've talked, I mean, we did a podcast with you earlier regarding the second book, but this book, the first one, Gut Feelings, a guide for patients and doctors, it really talks about the biopsychosocial approach to care and the importance of these communication skills. Like we could have like 5 hours sitting here and talking about all these skills, but in the book, you really break it down with great examples. So we encourage patients to, check out the book. The link is in the presentation, but it's also available on your site at drossmancare.com. Look for the Gut Feelings book and you can find it. But I encourage everyone to check it out because it really gives you great skills and a better understanding of how to communicate, because it really is collaborative decision making. It's not just the doctor telling you what to do. It's not just the patient saying, I want to do this, but it's really listening, like Dr. Drossman outlined, and coming up with a plan together based on this powerful communications that you're doing and understanding.
The book also contains, it's a compendium of all the disorders of gut-brain interaction, IBS-C, constipation, dyspepsia. So if you have a DGBI, you can learn a lot about it in a more abbreviated way.
Yeah, no, this is great. So I always thank you for bringing up the book again, because it's such a powerful tool.
You know, a lot of patients feel really intimidated to be honest and open with providers, or to ask questions, or to even be a part of the treatment plan decision, right? They feel like this white coat is this, like, you know, enigma of honor, and it is, and doctors are experts. But I think patients need to understand that they know their body best, they know their needs best, and they have every right to be a partner in that care. And so, you know, really kind of expecting that is important. And if you don't find that initially off the bat with your physician, it's okay to go and find someone who will be your partner, and who will, you know, provide that empathy and that support and that education, and let you be a part of that decision making, because it's everything when it comes to managing these chronic conditions.
100%. And you raised another issue. You know, it's like when you're given a treatment plan, if it doesn't work in a week,
Yes.
don't give up. A lot of times this takes a month or 2 months, sometimes longer, to take effect. And
Absolutely.
on the flip side, if you're feeling good, don't stop it unless you talk to your provider, because then you'll start the whole cycle all over again. But I want to bring up another point about, you know, feeling, you know, in the age of the internet, you know, and Dr. Drossman, you're going to be great at answering this. You know, we want to have empowered patients that are educated, that bring tools and information to the doctor. But what we don't want is reams of paper that you print out from Google that takes down a path that is ineffective. And we're not saying don't be educated, but how do we talk to patients and be like, look, we want you to be empowered partners in your care, but we don't want you to go down rabbit holes coming to the doctor's office with reams of information. You know, how do we temper this, and what's a compromise, and how could we come to the office prepared but not overwhelming our physicians?
Yeah, well, you know, I think that doctors, with the internet age, doctors have had to deal with the interaction very differently now, because in the past, patients would just listen to what the doctor said, or they might read something in a book. But I think the doctor, the burden is on the doctor to play a mediating role. And I know that when patients can come up with ideas, sometimes they can be very extraordinary, things I've never heard of, and things that don't often make a lot of scientific sense. And so I try to give my best knowledge. The other thing a doctor needs to do is to say, well, I'm not familiar with this. This may sound reasonable. Let me read about it and get back to you. And I think from this, maybe Johannah can speak to the patient's point about how to prepare for that.
Yeah.
But I think from the doctor's standpoint, we need to be open to ideas, but also to temper them, to analyze them, and to provide what information we know. And if we don't know, say we'll get back to them.
Love it. Johannah, from the patient side?
I mean, I always tell patients, you need to be very careful about Googling your symptoms. You will end up down a rabbit hole. And a lot of the stuff that you're going to find is not evidence-based. It's not scientifically factual. There's no good data to support it. And so it's important to be an educated patient, but to be really wise in that process, and to vet some of this information carefully. And so I give examples of good reputable sites to look at, you know, your site, Jackie, the Rome Foundation, IFFGD, ACG, HGA, some of those, you know, very valuable sites for patients that have patient information that we know is going to be good and trustable. But in terms of preparing for a visit, you know, I think it's great for patients to spend maybe a week before the visit kind of journaling their symptoms and the foods that they ate and kind of what happened that day, so that they can kind of identify any triggers that might make their symptoms better or worse, their sleep patterns. Those sorts of things are all going to be helpful when you get into that visit and you have that little tiny 15, 20 minute, time frame with your doctor, because many times you forget some of that stuff and you're not as efficient in the time that you have. And so just spending a little bit of time doing that and making some notes is helpful. Making a list of the medications you're taking, the dosage of them, anything you've tried over the counter or that you're using over the counter is going to be important as well, including any supplements. That's really important. Many people don't think to tell doctors about supplements, but they can have some adverse interactions with medications. So that's really important. Any tests that you've had in the past that maybe your doctor is unaware of, any emergency visits, those sorts of things. All of that is going to be important to kind of have in hand and have prepared so that you can make the most of your time with your doctor.
Yeah. And any life changes, like the patient in the video was going through a divorce. That's huge. Or a job loss, a death in the family, something that was traumatic that happened to you. The other thing is, and this is something I think that women especially can relate to, when it's the time of the month and you have those massive cramps, in that moment, they're horrible. But then if by the time you have the doctor visit a month, 2 months, 3 months later, it doesn't have the same intensity. So write down that intensity in that moment in your journal, like Johannah mentioned, of how you felt. Maybe make a face, or it was awful, or something that can trigger your memory when you talk to the doctor, so they really understand, or she understands how bad you were feeling.
Yes, it's very important. I always talk to patients about making sure that they discuss the impact on their quality of life. If gosh, doctor, over the past month, I've missed 5 days of work. I wasn't able to go out with my friends. I haven't been to the gym in 6 months. My kid's soccer game was postponed because I couldn't make it. All of these things are important for your doctor to know, because that's going to indicate how severe your symptoms are. And that may change their treatment recommendations. Yes. So all of that's going to be important. And many times we don't think about, like, why would the doctor care about how many days of work I missed? Well, that's a part of your life, and they need to know that, because we're looking at a biopsychosocial approach, as you mentioned. So absolutely important.
As we close up, what are your final tips, particularly for patients? I know it relates to all patients, but particularly for patients with IBS-C who may be struggling with some of the pain and the embarrassment, and they're not satisfied with their current treatment plans. What are some tips for beginning the dialogue with their patient, with their doctors on, like, I think I need to try something else?
Yeah, well, I think first of all, knowing that you're not alone. IBS-C and chronic constipation are very common conditions. A lot of patients have them and deal with it on a daily basis. So knowing that, you're in good company. And when it's time to seek medical advice or change your treatment, there are a lot of good options available out there in conjunction with some dietary changes and maybe even with some behavior modifications. You can find good relief. And so if something that you're on is not working, definitely have that conversation. Don't be embarrassed. As I mentioned, your doctor has heard everything before, and be really truthful and honest about the impact of it on your life, and see what you can do together to make things better.
And Dr. Drossman, for those patients that might worry about offending or disrespecting the doctor if they want to change a treatment plan or do something different or question the doctor's plan, what are your tips for those patients?
The approach is not to put the doctor in a position like they're being criticized, but to speak about your own experience and the difficulties you're having. So instead of saying, I'm not getting the right treatment from you, you might say, I'm struggling with the treatments where we have right now. Is there any other options we can consider? So it's part of the collaborative from the other side. I would point out that in the book we just published, The Gut Feelings, we have a whole section on how patients should talk to doctors. So, and that can be found on their own foundation, as well as Drossman Care sites.
So was that the first book or the second book? I'm confused. The one that you showed.
The one I showed just now
was the first book.
First book.
Yeah. Okay. So I got it right. Okay.
The second book, which is the patient stories.
Yeah. I thought I got it right. Okay.
Yeah. And both books, by the way, have another thing, which is a listing of the top neurogastroenterologists dealing with these disorders around the world. So you can find a doctor perhaps in your state by looking at the book.
No, this is great. And we also have resources on GI On Demand and Gastro Girl, as does the Rome Foundation for behavioral health and GI and psychogastro, as you like to call it. So this is all good stuff, but I thank you both. This is so exciting and so interesting. I can't wait for this episode to drop. Really appreciate and look forward to continuing the conversation in the new year.
Sounds good.
Thank you.
Thanks for having us.
Thank you. Thank you.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.